Hello, everyone, and welcome to the 2020 ELC Virtual Conference Keynote Address. My name is Caroline Goulet, and I am the Secretary of the Physical Therapy Learning Institute Board. I am stepping in this morning for our President, Dr. Barb Tschoepe, who is facing some technological difficulties. So I have the privilege to welcome you to the 7th Annual Geneva R. Johnson Forum on Innovation in Physical Therapy Education. Our theme for this year's forum is Population Health in Physical Therapy, Preparing Graduates to Address Societal Health Challenges. The GRJ Forum is sponsored by PTLI, and on behalf of our Board of Directors, I want to thank the Board of the American Council on Academic Physical Therapy and their president, Dr. Barb Sanders, and the Board of the Academy of Education and their president, Dr. Pam Levangie, for their ongoing collaboration to help us bring the forum to all the stakeholders interested in physical therapy education. Our visions intersect as we each in our unique ways strive to promote excellence in physical therapy education. The forum is named in honor of Dr. Geneva R. Johnson, PTLI founder and recognized as one of our greatest inspirational and visionary leaders in physical therapy for over 70 years. Jeannie led, inspired, or mentored many of us to embrace her passion for innovations in education. She is credited for being one of our first to envision doctoral education for all physical therapists, as she was and continues to be a firm believer that we have a role as primary care providers to serve with humility and empathy as movement systems experts. Dr. Johnson founded the Institute in 1991 in collaboration with Dr. Linda Woodruff, initially as a think tank of accomplished and developing leaders who they believed could influence positive change in our profession. Jeannie's messages are simple. She has 3 P's of successful leadership: passion, persistence, and patience, while she continually reminds us that our destiny depends only on us, and that if we use our heads, hand, and heart, we can overcome any obstacle to create a positive future. Today, PTLI continues to build from Jeannie's and Linda's legacy as we aspire to challenge the status quo and ignite change through innovation, collaboration, and actions to advance education, research, and practice in physical therapy. I encourage you to visit our website to learn more about our other initiatives that we expect will also ignite change. As an example, in collaboration with others, we hosted the first annual Linda D. Woodruff Lecture on Diversity, Equity, and Inclusion, which, as many of you know, was Linda's lifelong passion. And we plan to roll out a 3rd initiative in 2021 on disruption innovation. In each case, we hope to engage our community in dialogue that will drive change in these respective areas. Unlike other distinguished lecturers of our profession, the board collectively want to create a safe space for dialogue about the possibilities for the future, serve as an incubator to drive innovation and challenge the status quo, promote collaboration to transform ideas into action, disseminate highlights to the broader professional community, prepare graduates with leadership skills and moral courage to address societal health challenges now and into the future. The GRJ Forum has 2 distinct parts. The first hour will be our keynote address, bringing population health perspective to physical therapy education. The second hours, we will have 3 panelists, including our keynote speaker, and that will be moderated by myself. In the second part, we are trying to engage the audience in the discussion. Before I turn over the hour over to our keynote speaker, I want to recognize and thank 2 PTLI board members for their generous donations that is instrumental to help PTLI fund the cost of the forum, Beth Whitehead and Dr. Steve Tepper. I would like now to introduce you to our keynote speaker, Dr. Alan Jette. Dr. Jette's research focuses on evaluation of rehabilitation outcomes, functional measurements, and the prevention and treatment of disability. He served as Dean of Boston University Sargent College of Health and Rehabilitation Sciences from 1996 to 2004, and was Professor of Health Policy and Management at the Boston University School of Public Health from 2005 to 2017. He currently serves as Professor of Rehabilitation Science at the MGH Institute of Health Professions. In 2013, Dr. Jette was elected to the National Academy of Medicine, formerly the Institute of Medicine. He is the editor-in-chief of the journal Physical Therapy. And today, he will be talking with us about a very timely topic for 2020. Bringing a population health perspective to physical therapy education. As we transition to Alan's slides, I want to welcome you to post any questions that you might have for Dr. Jette in the Q&A option. As time allows, he will address these questions at the end of this presentation, and whatever we aren't able to get into this session will be transferred to part 2 of the forum with our panelist fire chat. Thank you. We are aiming to finish this session by 11:55 to give everyone time to transition to the next session that starts on the hour. Thank you.
Thank
Dr.
you.
Jette.
Thank you, Caroline. Can you see my screen?
Yes, we can.
Okay, great. Well, let me start by first thanking you for that very kind introduction. And I also want to take the opportunity to thank the Council of Physical Therapy Education and the organizers of the conference for the invitation to speak with you today. It's a great honor, and I have been looking forward to the opportunity to share some of my thoughts with you, and I look forward to the discussion in the second hour. Let me begin with a disclaimer. I don't pretend to be an expert in physical therapy education. And when I talked to the organizers of the conference, they assured me that that was fine. That was part of the reason they wanted me to come and talk. So here I am in my home office. Unfortunately, we can't be together in person in Milwaukee. I was looking forward to that, but this is a good second choice. So with that disclaimer, I as was noted in the introduction, I do have some experience in the field of education, and I have a lot of experience having worked in schools of public health for much of my career. And so what I thought I would do today is kind of share with you some of my thoughts that I've picked up over the years and in my reading having to do with population health, and then discuss with you some of the implications for that for those of you who are engaged in educating the next generation of physical therapists. And so when you think about the IHI quadruple aim, I'm going to, of course, focus on improving the health of populations. I'll leave to others the discussion of some of the other components of the quadruple aim. So I think the best place to begin is to ask the question, what do we mean when we talk about population health? In preparing for this talk, I read quite a few articles written about how people think about population health, and I'm going to share with you the one that I thought made the most sense to me. There's several elements to population health. The first is it's an approach that focuses on interrelated conditions and the determinants of the health of populations over the life course. And a population health perspective identifies systematic variation in the pattern of occurrence of these interrelated conditions and their relationship to the determinants. In essence, the first two elements of population health, from my point of view, have to do with epidemiology. The third element goes well beyond epidemiology, and that has to do with applying the resulting knowledge from the research to develop and implement policies and actions that improve the health and the well-being of the target populations. So the first two elements focus on what I would see as traditional epidemiology, but the third goes well beyond and focuses on the application of resulting knowledge to develop and implement policies and actions. So I'm going to talk about each of those elements of population health as I see it relating to what we do as physical therapists. Now, for me, in addition to having studied public health, both gaining an MPH and a PhD in public health at the University of Michigan, my first introduction beyond my graduate study was reading about Dr. Jeffrey Rose, who was in the London School of Hygiene and Tropical Medicine. He wrote what I consider a very influential series of papers and then a book in 1992 called The Strategy of Preventive Medicine that had a real impact on my thinking about rehabilitation and my area of interest, disability. Rose talked about what he referred to as the prevention paradox. And what he described was a high-risk strategy to prevention, where we clinically orient our approach to focusing on efforts on individuals or patients with the highest levels of a risk factor, a very targeted focus on vulnerable individuals. As I think about the high-risk strategy, I think Rose is talking about what we do as clinicians. We try to bring much benefit to the individual, but we have a relatively small impact on the population. That's the paradox. In contrast, Rose wrote about what he referred to as the population health strategy, where the focus, instead of focusing on patients, it shifts to a population distribution of a risk factor. And so the focus is on trying to shift the risk factor distribution in a population, in the community. And in doing so, the individual benefit to a specific person or patient is relatively small. But if you can shift the overall distribution, the population impact is quite large. And he referred to this as the prevention paradox. And I think that has a lot of relevance to those of you who are interested in taking a more population approach to the education of future physical therapists. Now, it had a great impact on my work in disability. I was heavily influenced in my early research on the work of a sociologist, Saad Nagy, who talked about the main determinants of disability as being pathology, impairments, and functional limitations. And that really influenced the early epidemiology work that I did in trying to understand what were the major determinants of disability in individuals and in populations. And then in 1994, a colleague, Lois Verbrugge, and I wrote a paper that really tried to describe a more population approach to thinking about disability. And instead of just looking at pathology and impairments and function, we brought in some of the broader elements that may influence disability in a population. Someone's demographic background, their biologic or behavioral risk factors, or the physical and social environment. And we took a much broader, what I would refer to as a public health approach to thinking about, in this case, disability. And that really influenced a lot of subsequent work that has been done in trying to understand the epidemiology of disability. We've learned in subsequent research that disability is not only influenced by pathology, impairments, and function, but also by background factors in the individual as well as the environment. It's a classic public health approach where the focus is on the agent, the host, and the environment. But instead of applying it to disease epidemiology, we applied it to disability epidemiology. And this approach was codified subsequently in the World Health Organization's ICF framework and model. And so that work that Rose did really influenced my thinking about public health, at least in terms of the epidemiology. But it doesn't really address the third factor in a population health framework, and that is, what does it mean to take action at a population level or a population perspective? And here, to illustrate taking action at the population level, I want to use the example of smoking in the United States. 50 years ago, 42% of American adults smoked. Tobacco use was seen as extremely glamorous. You could smoke almost anywhere. The societal norm was very much in favor of using tobacco and smoking. Over the past 50 years, as illustrated in this chart, that has changed dramatically. The prevalence of smoking in our adult population has gone from over 40% to under 14% of the population in the most recent data that I could find. That is a remarkable transformation in the prevalence of an extremely important risk factor for so many different diseases and negative health conditions. And it's a profound success. And so the question that I would ask of you is to say, what is it that led to such a successful transformation in the prevalence of such an important risk factor? Well, as I look at the literature on smoking and reduction in smoking behavior in our population, there are some very important clues of what really had an impact. And I'll summarize them on this slide. First of all, there was a great deal of emphasis on mass communication efforts to get the word out about the importance and the negative impact of smoking on the incidence of cancer and other health conditions. That was followed by restrictions on marketing of tobacco products. And then an intensive focus on non-smoking, anti-tobacco curricula in schools, having an impact on the next generation, all of which led to a denormalization of smoking in our culture and in our society. It also involved increases in the unit price for tobacco products, putting additional taxes on tobacco products, which were also related to reducing the demand and use of those products. And then comprehensive policies for smoke-free environments to reduce involuntary exposure to secondhand smoke, which the epidemiology has also shown to be related to cancer and other negative health conditions. So it's a tremendous success story. And if you look at these major interventions to reduce smoking in our population, what really stands out to me is that if you look at the literature, it's not clinical interventions with people who smoke that really transformed the epidemiology of tobacco use. It was population level interventions. It's a huge public health success story, which I think has a lot of implications for those of us in physical therapy and those of you in physical therapy education. So let's talk about that. And my starting point for thinking about a population approach to physical therapy education is to go to the vision that the APTA has put forth for our profession. What I would describe as a very radical vision. Our vision as a profession is to transform society by optimizing movement to improve the human experience. That's a very substantial departure from our previous vision, which focused on becoming doctors of physical therapy. It focused on direct access to our services, becoming providers of choice, and having autonomous practice. That previous vision was very inward looking and trying to enhance the professionalism of ourselves as physical therapists. We have shifted emphasis to a very outward looking and very radical vision, one that I totally support, of transforming society by optimizing movement that will improve the human experience. Now, if we take that vision seriously, it has, I think, really important implications for those of you who are educators in physical therapy, and I want to talk about that. So how does our vision to transform society relate to what we know about the major determinants of health? And again, in preparing this talk, I went to the literature and I looked at what we currently know as the major drivers of population health. And I'm just going to show you two figures that summarize my take on the current understanding. And then I'll talk about its application to physical therapy and physical therapy education. This figure comes from the University of Wisconsin Population Health Institute. And the focus is on strategies to build a culture of health. This work is supported by the Robert Wood Johnson Foundation. And they were trying to encapsulate in this figure the major drivers of population health. And I want to call a couple things to your attention. First, the role of clinical care. 20% of the major determinants of population health, according to this group, is driven by the kind of care we provide to our patients, clinical care, 20%, having to do with things like access to care and the quality of the care that we provide. By no means minimizing it, 20% is a substantial proportion, but it's a relatively minor proportion relative to other drivers of health of our population. The second major element I want to call your attention to is the role of health behaviors, personal health behaviors. In this model, 30% of population health is believed to be determined by our individual health behaviors: tobacco use, diet and exercise, alcohol and drug use, sexual activity. 50% of the determinants of population health are driven by clinical care and health behaviors. And then the other 50% is driven by social and economic factors and the physical environment. elements totally outside of the kind of work that we do clinically with our patients. This is a different figure that illustrates the same breakdown of major determinants of health in a population, and it's a little different. It breaks out the element related to genes and biology relative to clinical care, and otherwise it's very similar. But I thought the genes and biology component was useful to think about as well. But the take home for me is that if you think about determinants of health at a population level, clinical care is really going to drive a small portion of the determinants of health. So, given our vision to transform society and what we know about the epidemiology of the major determinants of population health, what is the rightful lane for physical therapists? So I'll share with you some of my thoughts on this. Now, on the one hand, many writers have talked about the dangers of thinking too broadly about population health. The argument here is that teaching about population health and social determinants of health may distract students from their core business of being taught areas of clinical diagnosis and intervention. And there are many authors who write about that, and I reviewed much of that literature where they raise real red flags about focusing too much on population health because it will detract from the main focus, and that is helping students become competent in areas of clinical diagnosis as well as intervention. However, we can't ignore the fact that overall clinical care that we provide only accounts for 10 to 20% of health outcomes, and personal health behaviors account for an additional 30 to 40%. Social and environmental determinants drive a majority of the variation in health outcomes. Now, if our vision for physical therapy was to become autonomous practitioners with providing patients with direct access, then I wouldn't see any problem with focusing our attention on clinical care and personal health behaviors. However, if we're serious about transforming society, if you think about what we currently know about the major drivers of health in our population, then I have to wonder whether we'll be successful if we really just limit our focus to being outstanding clinicians. So I went to the literature in our field and took a look at what some of the experts were writing about in the field of physical therapy. I want to share some of what struck me in that literature about what we should be teaching our students. Dean has written quite a bit about this topic, and I've focused here on two articles that she published, one in 2009 and another most recently in PTJ in 2020. And her focus is that physical therapists, at least as how I interpret it, physical therapists need to redouble our efforts to address non-communicable diseases by assessing patient risk factors and instituting evidence-based health education and other interventions or support efforts when those are being managed by other professionals. In other words, Dean is saying we need to look more broadly at risk factors for negative health outcomes and really try to focus our attention in those areas, such as physical activity, but not limited to that, smoking cessation, nutrition, and weight control. So that's what Dean is arguing. From my perspective, that's still a fairly clinically oriented approach where our attention is focused on our patients. albeit a broader focus than maybe a more traditional approach. Besner and colleagues published an article in 2015 where she and others advocated that physical therapists should be promoters of health and wellness very broadly, identifying non-communicable disease as a major cause of morbidity and mortality, and again, paying routine attention to these risk factors, such as tobacco use, activity, nutrition, and weight management. So very much in line with what Dean is arguing, taking a much broader perspective. I was very interested in this recent article. We just published it in PTJ in September 2020 by Dawn Magnuson and her colleagues. And it's an actual empirical study on population health, prevention, health promotion, and wellness competencies in physical therapist professional education. It speaks very directly to this topic. She and her colleagues put together a panel of 37 experts, and they did a 3-round Delphi process to inform the development of population health, prevention, health promotion, and wellness competencies for physical therapist education. 25 competencies emerged with considerable consensus across the 3 Delphi rounds. 18 of them focused on preventive services and health promotion, very similar to what Dean and Besner were focusing on in their writing. 4 of them also focused on the foundations of population health, and 3 on health systems and health policy. The majority focused on clinical preventive services and health promotion, very much staying in our primary wheelhouse of taking an individualized and patient-centered approach to physical therapist practice, albeit focusing more broadly on prevention and health promotion, but the focus being on our patients. However, the participants in this study clearly endorsed the need for students to have some foundational understanding of population health, recognizing the epidemiology of health, identifying key health indicators for monitoring population health, and how to access sources of population data. So clearly that did emerge. A foundational understanding of population health was felt to be important by a consensus of these educators and experts. The participants perceived health system and policy competencies as clearly being relevant to physical therapist practice, but beyond entry level and not a focus of entry level education. Well, I found that fascinating. And here, competencies that were not endorsed are primarily the population health strategies, balancing societal needs and economic efficiency in the delivery of prevention and health promotion, summarizing the process of prevention and health promotion policy making at all different levels, supporting policy initiatives, supporting policy initiatives that promote healthy communities, supporting community designs that promote opportunities for safe physical activity and active transportation, advocating for the coordination of data and services across health sectors, defining and advocating for the physical therapist's role within an interprofessional disaster preparedness team. The participants in this study, as I read and interpreted, felt that these were important areas for physical therapists to be involved, but should not be a focus of entry-level physical therapist education. So some foundation in population health, but not going too deeply into it. And then Guthrie, Dumholt, and Kean wrote a very interesting article in 2018 where they talked about a series of population-based practice activities that physical therapists should be involved in. And one of those, it does focus on advocacy and policy development, in addition to screening and outreach, referral and follow-up, health teaching, health coaching, consultation, and collaboration. So a fairly broad approach to physical therapist practice. And then finally, I want to call to your attention a really interesting point of view article that Dean and Pam Duncan published in PTJ in 2016. And they talked about preparing the next generation of physical therapists. And they were using as the example the Macquarie University in Australia. And they argued in this article that the next generation of solutions to health of our populations will require new skills among physical therapists, and that we need to be partners in the treatment of populations, not just our individual patients, but populations across the continuum, focused on lifestyle management. And they went through in this article and outlined the curriculum that they're using at this university in Australia. And it does focus on the more traditional areas, and then in semester E, an extended knowledge of future leadership, and then finally independent clinical research in semester F. So I call that to your attention. You might be interested in taking a look at what our colleagues in this particular university in Australia are doing. So as you can see in what I have reviewed in the literature being written by physical therapists, there's some very strong advocacy for going beyond the traditional focus on clinical treatment of individual patients, including a broader focus on health promotion and wellness and prevention with our patients, and then some touching on a foundation of population health, but not an intensive focus on population health as I read the literature. So I also want to share with you some recent work that Don Berwick published in JAMA Network just in July of this year, which I also found very provocative and very helpful as I thought about population health and physical therapist education. As you may know, Don Berwick started the Institute for Healthcare Improvement, which was started actually in Cambridge, Massachusetts, next door to Boston. And for a short time, he was the director of the Center for Medicare and Medicaid. He's a real innovative thinker in healthcare policy. Well, Don wrote this article in JAMA Network just this past summer, and he argued, and of course his timing was impeccable. Here we are in the midst of the coronavirus pandemic, and he writes, "Healers are called to heal. And when the fabric of communities upon which health depends is torn, then healers are called to mend it." And I think if you read the article, he's really struck by what is going on in the epidemiology of the coronavirus pandemic. We're not all in this equally. Certain populations are being far more affected than others in the COVID-19 pandemic. And so what Don argued is what he refers to, that we should be focused. And of course, his focus is on physicians. He's a physician by background, but I think it applies to other health professions as well. He focused on what he described as the moral determinants of health. And so they're listed here: speaking out, writing opinion pieces, working with community organizations, organizations that can develop programs to ensure proper care for people who are incarcerated, as well as people who just don't have access. helping create paths for return to work and return to society for those who are incarcerated, becoming engaged in identifying needs for housing and food security, helping develop community resources that encourage physical activity, lobbying for universal health care, working against implicit and structural racism. So speaking out, developing, helping, becoming, lobbying, working together. Very much population-oriented strategies that he argues really should be the moral determinants of health that we should be focusing on. And he acknowledges in this very, very enjoyable article that honest and compassionate people can disagree about the role of healthcare providers in improving social conditions and countering inequality and fighting against structural racism. He acknowledges that not everyone will agree with him, and some believe we should focus on traditional caring for illness, what some refer to as staying in our lane. And others, including Berwick, argues for expanding the role of clinicians and health organizations to demand and to support societal reform. And I think he really makes a strong point that we really have to think about as physical therapists, particularly as a society, focus more on non-communicable diseases, some of which are very much in our wheelhouse, such as physical inactivity, which is in epidemic proportions in our society today. So that's kind of a review of what I learned in reading and thinking about population health and how it might relate to our field of physical therapy and rehabilitation. So what should our educational priorities be for physical therapy education? Here are some of my thoughts, and I look forward to discussing them with you in the next hour. Clearly, we can't lose our primary focus. We have to make sure our students are prepared to provide high quality clinical care to their patients. So I think that's definitely in our wheelhouse, and we can't lose sight of that. But I think we have to go beyond that if we are serious about our vision of transforming society. Doing quality clinical care for our patients will not transform society. And if that's okay for our profession, then we stay within this wheelhouse and we stay within that lane. But if we're serious about transforming society, I think we need to focus beyond that. Behavior change is clearly important because we know behavior does influence health of the population, and the epidemiology supports that. And so I believe our students must be prepared to practice behavior change with their patients, but it must be sophisticated. We need to go beyond patient education, because there's a wealth of literature that shows just educating patients typically does not change behavior. And so we need to understand the major theories behind behavior and behavior change and help our students learn how to use those in working with their patients. But then I also think we need to go beyond our patients, and we need to help students learn how to get involved at the organizational and policy level. Moving beyond the high-risk approach, as Jeffrey Rose would talk about it, and begin to really move toward population strategies in addition to what we do as clinicians at the individual patient level. So I do agree with the folks in Australia, Dean and Duncan, who argued that we need to prepare a generation who will provide leadership in population health. And we need, I think, as educators, to develop leadership, policy, and advocacy curricula that's going to provide a foundation for our students and the next generation of physical therapists. Now, I fully recognize that not all students are going to become interested in population health, and not all physical therapists are interested in population health, and that's fine. But I do think if we provide a foundation for leadership at the policy and advocacy level, at entry level, it will help us identify those future physical therapists who would be prime to get involved at that level. I've seen medicine do that for years now in my work at Boston University, where they have offered MD and MPH programs so that medical students who were interested in getting more involved in population health could study for an MPH degree at the School of Public Health while completing their MD degree. And it's a small minority of students, but I think by providing some foundational work in population health, it helps encourage those who really are interested to get involved. So I do think we need to help students develop the necessary attributes, knowledge, and skills in health leadership, policy, advocacy to transform policy related to health. Why not? And so these are some examples of some of the skills. Functioning as in an interprofessional team, coordinating care across settings, how to collect and use data, learning strategies to accelerate the adoption of evidence-based practice, advocacy to reduce health inequities, advocacy for healthcare policy reforms, advocacy for social policy change. These are areas that I think we need to get involved in and need to help our students become skilled in if we're going to have an impact on society. And then for those students who are really interested, I think we need to provide opportunity for further in-depth study. Things like the DPT MPH dual degree. When I was dean at Sargent College at BU, we instituted a dual degree DPT MPH degree so that students who were really passionate about population health could delve into it more deeply. Medicine has done this very successfully for many years, and I know some DPT programs are doing it across the country. Some DPT programs are actually in schools of public health, so it's a tremendous opportunity for those students who are really passionate. Now, as I was preparing this talk, I was really struck as I was following the campaign of fighting the cut that the APTA launched. I realized that we, in fact, are really developing really good skills at trying to affect healthcare policy in our country when it really affects us. And so the campaign for writing Congress to oppose the 9% cut in Medicare funding, I thought was an extremely aggressive and extremely impressive campaign. I see this as a wonderful example of the kind of campaigns for social policy and health policy change that we need to be engaging as examples to our students that go beyond fighting the cut. You know, it's easy when we're fighting a cut that's going to hit our bottom line and directly affect our patients. It's much more challenging, and I think eventually much more impactful if we have campaigns like this that go after changing healthcare policy at the population level to really have an impact as a physical therapy profession. And in doing so, provide wonderful examples and role modeling for our students. So in closing, in my thinking, I think we have to expand our lane beyond clinical care if we're serious about the vision that we have articulated for our field of transforming society by optimizing movement to improve the human experience. As we have seen in other areas like tobacco use, population change can succeed. And in the next 50 years, for example, if we as a profession really focused on changing the activity levels in our population, we could have a similar impact on the health of our population as was had in the tobacco population campaigns of the past. So thank you, and I look forward to discussions with you.
Dr. Jette, thank you so much for this very thoughtful and provocative conversation about what we as educators might need to be doing and considering as we move forward. I also want to thank my colleague, Dr. Carolyn Goulet, who covered for me during the introduction as I lost internet, which is always a fun thing.
Barb, that's great.
At that time, right? But I am back. There's been a couple of questions that have come up, and we have about 5 minutes, so I want to try to address a couple of these questions, and then we'll move the questions as we move over to part 2 and to the panel. But the first question relates, and I think it is a follow-up of what you were just mentioning, and that is the pandemic. The pandemic has given us new opportunities and new urgencies for some of these topics that you've been talking about, particularly the topic about the importance of physical activity. Ellen is asking us, how might we be able to do a better job at portraying that importance and the role of the physical therapist in relationship to physical activity? Because that doesn't seem, we haven't been able to, shall I say, we haven't been able to successfully infiltrate the importance of the physical therapist's role. Can you help us with that?
Well, I agree. At the population level, physical activity is clearly within our wheelhouse and an area where we could have a profound impact. Well, the example that I used at the end in opposing the cut for Medicare services is the kind of visible, organized campaign that I think we need to be undertaking, not for the purpose of promoting the role of physical therapists. I think we have to get beyond that. We have to stop worrying about promoting ourselves. You know, when physicians are out there trying to, for example, change smoking behavior, they're not trying to promote medicine. They're trying to affect use of tobacco products. So my view is we need to shift the focus away from us. By doing it, we will gain visibility as important players in the area of physical activity by our effectiveness. But our focus should be on affecting policy change and not so much on trying to enhance the visibility of our profession as important to the role of physical activity.
Okay, so a follow-up to that, another participant is asking a question that I think has relevance to this, and that is we are very passionate about our efforts to promote population health. However, we struggle because we are not being reimbursed in any way. So there's the pragmatic challenge of clinicians who are deciding how much time or what they can do in each of those to maintain a viability within their own practices. Can you respond to that?
Yeah, well, I understand. We all choose to do more than our day job. I mean, most professionals identify the areas that they are passionate about beyond their day job. And so what I'm advocating for is that our involvement in impacting population health should be one of those priorities, and not just at the individual level, but at the organizational level. This is where I think our chapters and our national organization could be profoundly helpful in really getting behind these kinds of efforts, even when they don't affect the bottom line of what we do as clinicians. So I think, you know, we all have choices about how we're going to spend our time. And so I think what I'm arguing for is that this needs to become a greater priority than it has in the past, if we're serious about that vision of transforming society. That's my starting point for where I'm coming from on this issue. I have to admit, I was shocked when the APTA came out with that new vision. It's a very bold vision if you really take it seriously. And it goes well beyond our previous vision. And it means we have to get out of our comfort zone and get involved in other areas if we're really going to affect change.
Mm-hmm. Great. Thank you. There are a couple of other questions, but I think I'm going to hold those questions so that we can move over to part 2. We're going to have to be signing out of this particular session to move on to the part 2 session. But I want to thank you from the bottom of my heart, because truly the things that you are saying is really what Jeannie Johnson would be saying if she was here able to talk to us. There is a beauty of the fact that we are virtual, which is Jeannie doesn't have to feel bad that she can't be sitting in front of you listening. She can be listening from a distance like the rest of us. So I'm sure she's sending and smiling as she's listening to things that she has been encouraging and promoting us to think about for many years as well. But you've done it in an amazing and an articulate way. We have choices to make as professionals, and I think some of the other questions relate to some pragmatics, but I think we can get to those in
Good.
part 2.
I look forward to it.
For sharing your expertise with us, and for encouraging us to really sit back and think from an educator's perspective, where are our priorities and how much time are we spending in each of our different needs? And from a practitioner perspective, how do we prioritize what's important to us and how we can impact societal changes as we move forward? So I want to thank everyone for joining us for this particular session. And I am confident that you'll enjoy the remainder of the conference and the experiences that we have on this virtual platform. So goodbye for this one, and we hope to see you in a few minutes. We will start promptly at 10, or really it's 12 Eastern, in part 2 of the Geneva Johnson Forum on Innovation in Education. Thank you.
Thank you.